today is for Dr. Rose to introduce our new members.
Yes, we are pleased to have 4 new members of the NIH Recombinant DNA Advisory Committee. Sitting over here, we have Dr. Glenn 9mar from the Scripps Research Institute, and his expertise is in adenovirus cellular interactions, and we appreciate, obviously, all of our new members coming in and agreeing to be on the committee. Sitting next up is Dr. Naomi Rosenberg from Tufts in Boston, and her expertise is in retrovirology and in immunology. Our next new member, wait a minute, I've lost, Dr. Heslop from Baylor College of Medicine in Houston, and her expertise is in pediatric cancer, lymphoma, non-Hodgkin's lymphoma, and I apologize, Dr. Nick Musica, and I apologize if I butchered your name, you can say it correctly, University of Florida, and his expertise is in adeno-associated virus. So I certainly welcome all of you. I appreciate your willingness to serve on the RAC and look forward to your contributions and participation. Yeah.
Next, starting with Dr. Franchini, I'd like everyone just to introduce themselves in a sentence or two, giving your name, your institution, and your area of expertise.
My name is Genoveffa Franchini. I work at the National Cancer Institute. My area of expertise is retroviruses and the vaccine development for retroviruses. And more recently, I started to work also on vaccinia virus, orthopox viruses, for vaccine development.
My name is Nick Mazichka. I'm from the University of Florida, and my area of expertise is adeno-associated virus.
My name is Madison Powers. I'm the director of the Kennedy Institute of Ethics at Georgetown. I do biomedical ethics and legal issues and health policy.
I'm Glenn 9mar at the Scripps Research Institute, and my area of interest is adenoviral vectors and host cell interactions.
I am Emmett Barkley from the Howard Hughes Medical Institute. My expertise is in laboratory safety and environmental health.
I'm Naomi Rosenberg from Tufts Medical School. My expertise is in retroviruses.
I'm Larry Johnson from the University of North Carolina at Chapel Hill. I'm a pulmonary critical care physician with an interest in lung biology and gene transfer.
I'm Martha Bone, director of the neurobiology program at Children's Memorial Hospital, Northwestern University, and I'm interested in gene therapy for neurodegenerative diseases.
I'm Rob Samari from the Mayo Clinic, with a cardiologist with an interest in gene and cellular therapies for vascular disease.
I'm Tom Galerter, Chair of Human Genetics at the University of Michigan. My research interests are in hormonal regulation of gene expression. I'm a medical geneticist, and I have absolutely no expertise to bring to this committee.
Untrue. I'm Diane Wara from the University of California, San Francisco, Division Chief of Pediatric Immunology, and my areas of interest are perinatal transmission of HIV and treatment of, including gene transfer, in babies born with heritable immunodeficiencies.
David Zadransky, Director of Head and Neck Cancer Research at Johns Hopkins. I'm a medical oncologist with an interest in cancer genetics and molecular determinants.
Bernard Lowe, University of California, San Francisco, biomedical ethics and internal medicine.
Jim Childress, University of Virginia, biomedical ethics.
Phil Johnson, Columbus Children's Hospital, and Ohio State University, adeno-associated virus.
Dave DeMetz, University of Wisconsin in Madison. I'm a biostatistician.
Maxine Lineal, Fred Hutchinson Cancer Research Center in Seattle, retroviruses.
Helen Hislop, Baylor College of Medicine, immunotherapy of malignancy and viral infections.
Terry Kwan, I'm a community panelist and come from the Boston area where I serve on 2 biosafety committees.
Stephanie Simic, Acting Deputy Director, Division of Cellular and Gene Therapy,
FDA CBER.
Christina Bohr with the Office for Human Research Protections within the Department of Health and Human Services.
Okay, as I do, excuse me, for every meeting, I want to remind the members about the roles of conduct and conflict of interest, being special government employees and RAC members. Being a member of this committee makes you a special government employee and thereby subject to the rules of conduct that apply to government employees. The rules and regulations are explained in a report titled Standards of Ethical Conduct for Employees of the Executive Branch, and you received a copy of this with your appointment, and it is available online. At every meeting, in addition to reminding you about the importance of following the ethics rules, we always like to review so everybody understands the steps we take and ask you to take to ensure that any conflicts of interest are addressed. Before every meeting, you provide us with information about your personal, professional, and financial interests. We use this information for assessing whether you have any real, potential, or apparent conflicts of interest that could compromise your ability to be objective in giving advice during committee deliberations. While we waive conflicts of interest for general matters because we believe your ability to be objective will not be affected by your interest in such matters, we also rely to a great degree on you to be attentive during the meetings and before the meetings to the possibility that an issue will arise that could affect or even appear to affect your interests in a specific way. If this happens, we ask you to recuse yourself from the discussion and leave the room. You are also required to recuse yourself from the preliminary protocol review process when you have an apparent, a real or an apparent conflict of interest involving a particular protocol. If you have any questions about rules of conduct, you may send those questions to me or to our committee management office. And thank you.
Next, we're going to review the minutes for two of our past meetings, October 17th, 03, and December 3rd to 4th, 03. And Ms. Kwan and Dr. Friedman are going to comment on those minutes. Ms. Kwan?
I just spoke with Dr. Friedman. Both of us reviewed these minutes. The October 17th meeting was the continuation of the second day of the September RAC meeting, which had to be canceled due to a hurricane. Most of the members were present via teleconference, and the minutes appear to be accurate. And the December 3rd and 4th meeting, which was the regular quarterly meeting of the RAC, and again, those minutes appear to be accurate, and I believe Dr. Friedman is in agreement. So I move that they be accepted.
Second, please. Second. Thank you. All in favor? We don't have to vote for this, right?
Yes.
But not by name.
Yes.
Oh, come on. All right. Apparently we have to vote by name. I can't stand it.
The rules.
I'm going to get this wrong. Dr. Moziska?
Very good. Yes.
Dr. Powers?
Yes.
Dr. Nemero? Dr. Barkley? Dr. Rosenberg? Dr. Larry Johnson? Dr. Bone?
Yes.
Dr. Samari? Gallagher? Wara? Sidransky? Lowe? Childress? Johnson? Demetz? Lenial? Heslop? DeLuca's not here. Ms. Kwan? Thank you very much. So we'll move on to our first review, and we're changing the arrangements for review just a little bit this time. We're going to trial it, and I'd like comments and feedback from everyone, including the public, regarding whether this is functional or not. At the conclusion of the presentation and the discussions, both by members of the RAC and by the public, for each of the protocols under review, we will then break for anywhere between 15 and 20, 25 minutes, and the break is listed as a part of your agenda. During that break, all those who had formal responsibility for review should stay in the room rather than going out on break, and anyone else who'd like to participate is welcome to. And we're going to attempt to format our formal recommendations during that time. We're going to do it so that it can actually be displayed when everyone comes back in the room. We will then display our comments, concerns and comments, so that everyone can look at them. Then we'll take a vote. The purpose of this is to try to concisely present our recommendation both to ourselves and to the public. And secondly, to present it so that RAC members will see exactly what they are voting for or against. We'll trial it. I don't know whether 15 or 20 minutes is adequate time, but let's see how it works. And at the end of today or at the end of the meeting, again, I'd like feedback from everyone on this. Our first presentation is Protocol 629, a Phase 1 dose escalation trial of a double-deleted vaccinia virus plus CD-SMR administered by intratumoral injection in patients with superficial injectable tumors. Dr. Bartlett will present as the principal investigator.
Okay, thank you. The title is a Phase 1 dose escalation trial of a double-deleted vaccinia virus, which expresses the cytosine deaminase gene and somatostatin receptor gene, administered by intratumoral injection in patients with superficial injectable tumors. This is what has been coined oncolytic viral therapy, tumor-specific replicating virus. The unique aspect of this, as was recognized in the initial review, is the fact that vaccinia has not been used directly for this purpose. While it has been used in clinical trials for expression of cytokines and as vaccines, it has not been used as a direct oncolytic. So this is a new use of this virus. And also, this is a different strain of vaccinia that has been than has been used before. This is a WR strain, which has some advantages as an oncolytic, we believe, over other forms of the virus. So those are the two unique aspects of this trial. The other tumor-specific replicating viruses that are in different stages of clinical development include adenovirus, herpes, parvovirus, Newcastle disease virus, Rio virus, and measles virus. And basically the concept is that a viral particle, for instance, a single viral particle could infect a tumor and then efficiently replicate within that tumor selectively and spread and infect surrounding tumor cells and get a very efficient spread of the vector through a tumor, either to directly kill the tumor or to express genes that would subsequently kill the tumor. The advantages that we see of vaccinia in this arena: it's a highly efficient virus with rapid replication and destruction of cancer cells. It's tumor targeted. Systemic delivery of the virus leads to high tumor uptake without any manipulation of the coat proteins. It's a large complex virus with the ability to insert genes and delete genes to enhance tumor selectivity. The safety profile is well known as a result of the smallpox vaccination programs. It's a cytoplasmic virus, so there's no chance for integration into the genome. And anecdotal reports of anti-tumor responses have been in the literature in patients given vaccinia virus as vaccines, as well as in trials in tumor patients. The tumor selectivity is not or the mechanism of tumor selectivity is not well established. We know that the tumor environment is a rich soil for this virus, and the virus replicates very well in these metabolically rich environments. Also, we believe it's such a large particle that extravasation into tissues is dependent on leaky vasculature, which may be more prevalent in tumor tissue. We had initially studied a virus which was deleted of the thymidine kinase gene. This is a mechanism of selectivity that has been used in herpes virus that's in clinical trials. So deletion of the thymidine kinase genes, tumor cells that have increased messenger RNA for thymidine kinase are basically complement the lack of thymidine kinase within the virus, and therefore the virus can replicate, whereas normal cells that aren't dividing, that don't have this rich nucleotide pool, cannot support the replication of the virus. So deletion of the thymidine kinase gene allows for the most efficient replication in tumor cells. We performed a variety of biomarker studies which have been published, as well as tumor response studies, but this is an example of an intraperitoneal delivery of the virus in a mouse with peritoneal carcinomatosis. And what we found was that with beta-gal expression, you could see very focal uptake and replication of this virus within tumor tissue, but in surrounding fat in the spleen here, for example, or the bowel here, you saw no viral uptake into the normal tissues. And so it appears to be very selective. We studied gene expression in the form of luciferase activity and found that, again, it was very selective for tumor tissue compared to all other tissues examined, the next highest always being the ovary, but many logs fold lower than what's seen in the tumor tissue. Because this intraperitoneal delivery was so selective, we went to intravenous delivery of the virus, examining subcutaneous tumors, and found similar selective uptake and replication in tumor tissue. Again, this is luciferase activity, which is logs higher than the next highest organ in biodistribution experiments, and eventually in these nude mice the virus disappears from the normal tissues and is only present in the tumor tissue. So very selective replication with just the thymidine kinase gene deleted. We've looked at a variety of other tumor models, adenocarcinoma, liver metastases in immunocompetent mice, subcutaneous sarcoma in the rat, VX2 liver metastases in rabbit, and human melanoma in athymic mice. And in all cases, we saw similar selectivity of this virus in tumor compared to normal tissues. And this is an example of an intraperitoneal delivery of the virus expressing green fluorescent protein and a subcutaneous tumor on the flank of a mouse. And as you can see, you get very bright fluorescence of the subcutaneous tumor without any other tissues lighting up, as a demonstration of the selectivity of this virus. So despite systemic delivery of the virus, it leaks out into the tumor environment and replicates very efficiently. And if you measure the percent of cells within that tumor expressing the gene 8 days after injection, up to 50% of the cells within the tumor are expressing the gene. So we believe it's very efficient at what it does. Despite the success with the thymidine kinase gene deleted, we did want to make this a safer virus, and in combination with the thymidine kinase gene, we deleted the vaccinia growth factor gene. This is a protein that is secreted by vaccinia-infected cells. It binds surrounding cells and through the EGF receptor stimulates those cells to begin dividing and producing nucleotides. So that in a sense, this vaccinia growth factor could compensate in normal cells for the lack of thymidine kinase, because it would bind and lead to thymidine kinase production in these cells. So by knocking this out, in addition to the thymidine kinase, it's really giving a double hit to the virus in normal tissues, whereas tumor cells, which all have some form of autocrine growth loop, do not need the addition of the vaccinia growth factor to prime them for vaccinia infection. And so just a schematic of the genome of the wild-type virus. The thymidine kinase gene is here. There are 2 vaccinia growth factor genes in the inverted terminal repeats of the virus. And we studied a virus which was deleted by insertional deletion of both the thymidine kinase by putting a LAC-Z gene in the thymidine kinase locus and a green fluorescent protein in the VGF locus. And we studied this virus for its selectivity in vivo and in vitro. We wanted to make sure that this mutant virus would still replicate normally in tumor cells, and so first looked at non-confluent NIH3T3 cells and showed that all of these mutant viruses grew equally well in vitro in tumor cells, and then studied the viral pathogenesis in nude mice, so mice without an immune system, because we know they are very susceptible to wild-type vaccinia. We injected 10 to the 8th plaque-forming units intraperitoneally of the different mutant viruses, and you can see that the wild-type virus without any mutations leads to the death of the animals fairly rapidly from viral pathogenesis. If we delete the vaccinia growth factor or the thymidine kinase gene alone, we see an advantage over the wild type in these animals without T-cell immunity, but the animals still succumb to the virus, whereas we see a remarkably improved pathogenesis when both the TK and the VGF gene are deleted. And now in these nude mice, we see very little to no pathogenesis. Likewise, if we look at biodistribution again and viral recovery from, in this case, the brain and the tumor, the brain being a perceived site of toxicity from this virus, we see that the wild-type virus in black can be recovered from the brain, although many logs less, or 2.5 logs less than what we recover from the tumor. So some baseline tumor selectivity, as we discussed. If we delete the VGF gene or the TK gene, we see a marked decreased recovery from the brain, but preserved recovery from tumor tissue. And if we delete both, on average, no recovery from the brain, whereas we do see preserved recovery from tumor tissue. So basically, this is the goal of any selective virus, which is to maintain replication in tumor, but markedly diminish replication in normal tissues. Based on this, we were able to deliver the virus intraperitoneally again to a subcutaneous tumor and see a dramatic anti-tumor response. Other tumor models that we have studied include the A2780 human ovarian xenograft model, where we saw all animals treated had a complete intraperitoneal response to the treatment. We also have studied this in a subcutaneous human colon xenograft model, the HT29, with dramatic responses both as an intraperitoneal delivery and as an intratumoral delivery. We have also studied this in non-human primates, and as a intradermal injection, here's a Wyeth strain of the virus, which is used in many clinical trials as vaccines. This is a New York City Board of Health strain of the virus, which we believe is the most common vaccine strain used for smallpox vaccines. And this is our virus here. So the skin reaction to this mutant virus is on the same scale as what is seen with the more commonly utilized viruses in the clinics. We also injected 10 to the 8th plaque-forming units intravenously of the double-deleted virus and saw no viral replication in tissues and saw no toxicity in the animals. So we believe that this, as this mutant virus, is safe. So what we would like to do is to move to the next phase, which is to begin clinical trials, and the trial proposed is a phase 1 clinical trial as a direct intratumoral injection. The virus is a mutant vaccinia expressing cytosine deaminase gene, which converts 5FC to 5FU. It is a suicide gene which has been used in clinical trials previously. It also expresses a somatostatin receptor, The purpose of this is that the somatostatin receptor will be expressed on the surface of cancer cells infected by the virus, and we will be able to image using a clinically available octreotide scan, a radionuclide scan to image in vivo gene expression. In this trial that we propose, because of the complexities of examining a prodrug in addition to the virus itself, and because this virus alone has not been studied in the clinics, we don't propose to use this prodrug conversion in the initial trial, but just to look at the effect of viral replication itself without the use of the prodrug. Patients with cutaneous and or subcutaneous tumors will receive intratumoral injection of vaccinia. Despite our demonstrating quite significant targeting of this virus as a systemic injection, and our goal would ultimately be to achieve that in humans, because this virus has not been used before, we wanted to begin with what we consider to be the safest mode of delivery, and that would be intratumoral injection in accessible tumors. And these would be cutaneous and subcutaneous tumors. The most common ones that we would be referred would be squamous cell carcinoma of the head and neck, melanoma, and recurrent breast cancer. These would be patients that have failed all standard therapies that could not be cured with surgery alone, and we would offer them to participate as subjects in this trial. Up to 3 tumors will be injected. We will inject a volume equal to 25% of the tumor volume. We will escalate from 3 times 10 to the 7th plaque-forming units of the virus to 3 times 10 to the 9th plaque-forming units in cohorts of 2 to 6 patients with a standard traditional phase 1 design. So 3 patients at each dose level looking for dose-limiting toxicities. If 2 out of 6 patients undergo dose-limiting toxicities, then that will be the dose-limiting toxicity, and we will move back down to a maximum tolerated dose. We will repeat the treatment every 3 weeks for a total of 4 cycles. We will follow toxicity, pharmacokinetics, shedding, viral replication, and response. Because this is a different trial than most vaccinia vaccine trials, we are very interested in how efficient this virus is replicating within the tissues, and we will obtain tissue biopsies looking for viral replication. In the future, if this trial demonstrates efficacy at a safe dose, then we would like to pursue regional treatment, and the next steps would be intraperitoneal treatment of peritoneal carcinomatosis and intraarterial treatment of liver tumors. Obviously, depending on what the initial study shows, we may need to redesign the vector, or we may need to utilize the prodrug activating enzyme for response. That's all.
Thank you very much, Dr. Bartlett. If you would like to sit down, we'll go through the formal RAC discussion. And I'd like to start with our ad hoc reviewer, if that's all right. Dr. Franchini? Thank you.
Okay, so what I would like to say is that reading this protocol was really a pleasure. It was very clear. It was very well presented, as it was the presentation that we just have heard. And I will just basically very quickly summarize. Please appreciate that this is the first time that I do this review, so I wasn't really sure what I was expected to do. But very briefly, I think that this the approach that has been chosen is a novel approach. I think that the approach of trying to selectively replicate this virus in tumor cells is novel. And there have been few studies before, but not with the same kind of genetically modified vector. And basically, it will increase not only the ability of the virus to replicate in tumor cells, as it has been demonstrated clearly both in vitro and in vivo, but also presumably will decrease the toxicity, because resting cells have neurons as well as T cells, where the virus can, T cells can be exposed to the virus because the tumors are highly vascularized usually. Will not be a target of infection of this virus, as well as other cells in our body, which are resting T cells. And the protocol is contemplating to treat, as you have heard, superficial, easily accessible, non-connected with important vascular sites, solid tumors, breast cancer, melanoma, squamous cell carcinoma, metastatic. And the primary endpoint is to evaluate the maximal tolerated dose given by intratumoral inoculation and the safety of the intratumoral inoculation of this vector. So the data that they presented, that has been presented in here, and also the paper that has been published, the papers that have been published clearly support both in vitro the fact that this vector has a reduced viral replication in human cells as well as mice cells, and there are also several supporting data in vivo that these vectors replicate quite well in tumor cells. So I think that, having said all of this, these are all very positive supporting data for this protocol. And the additional feature of the vector, as it has been described before, the idea was to add an inducible system with a drug treatment, but is not really the subject of biological evaluation in this study. And the addition of somatostatin receptor is also could be very useful, just to have an idea where this virus goes to replicate. One thing that was unclear to me, and I think that perhaps we need to have, perhaps the protocol might explain more clearly also to the patients that might be enrolled, is how much radioactivity will the patient be exposed to, how often this is going to be done, and how many evaluations are going to be done. It was unclear to me from the protocol. And one important issue, and perhaps this is my only important issue that I would like to raise, is the fact that some of these individuals probably are going to be more than 30 years old, and they have all been exposed to vaccinia by prior smallpox vaccination. And they will have neutralizing antibodies, most likely, in their serum. So we need to understand how this pre-existing vaccine immunity might influence the primary endpoints. In other words, if you have already neutralizing antibodies, then perhaps the maximal tolerated lesion, maximal tolerated dose might differ if you don't have a neutralizing antibody present. And I was wondering whether so therefore also safety, let's leave alone for a moment efficacy, because this is really not necessarily the endpoint of this trial, but the safety could be important, because inoculation of 10 to the 9, if you are vaccine naive, might differ than if you are instead vaccine experienced. And I was wondering whether since this data will be collected, the protocol is in this protocol, neutralizing antibody to vaccinia will be measured before the enrollment of the patient. I was wondering whether it might not be possible to use this, to use that as a parameter to model the phase 1 trial. In other words, if you know what is the level of the neutralizing antibodies that the patients that are going to be enrolled do have, maybe this should become a factor in terms of how then the dosing is decided in that particular group of patients. And the other issue are, clearly this also could be important for the tumor reduction, because for tumor reduction. So I was wondering whether it might not be possible in the future, perhaps to do a study in which in mice, in which it is possible to evaluate whether the addition of neutralizing antibodies, like the vaccinia neutralizing antibodies in a nude mice, using the transplant model that has been used, might actually affect the ability of this approach to kill the tumor cells. And lastly, I just have a few other things that I thought that might need to be clarified in this protocol. So as I said, the criteria of inclusion, one of the criteria that was mentioned was that the patients that are going to be enrolled should not be on treatment for at least 4 weeks. And I was wondering whether perhaps a criteria that reflect better the immunological status of individual could be used rather than just this 4 weeks from the last treatment. I think also one thing that I thought that it could be useful to have is to have a detailed guideline of what would happen in the unlikely scenario in which in some patients, perhaps some distal vaccinia replication that might pose some concern is observed. Where is the VIG coming from? How much is going to be given? There was nothing written regarding to this. And also, I think that in the patient form, in the form that the patient signed, perhaps we should advise them not only that they should not breastfeed if they are undergoing this protocol, but also if they have children in the household, they should try really to limit the contact with the children as well, because they will be totally vaccine naive. And finally, I thought that perhaps it should be defined better how the HIV infection is going to be determined, presumably both by serology as well as by PCR in the blood for plasma for HIV and so forth. So these are my comment on this protocol.
Thank you very much. Frequently we have an opportunity for the principal investigator or the sponsor to respond to our comments in writing. We didn't have that for this protocol. Dr. Bartlett, would you like to try to answer some of Dr. Franchini's points?
Thank you very much. I think those are all good points. The first one being, and probably the most important, is there a difference in toxicity based on the pre-immune status? And less important is going to be, is there a difference in response? In all of our preclinical studies, including the animal studies, we utilized non-pre-immunized animals and showed that this vector is safe. So our anticipation is that this is a safe vector in the non-pre-immunized host. However, I would say that we cannot predict for sure that the maximum tolerated dose wouldn't be different in a non-pre-immunized versus a pre-immunized host. And therefore, the easiest thing would be, and probably the safest thing would be, to separate out those that have no history of vaccination or no measurable antibodies in a separate phase 3 design, so that they would be stratified by their prior exposure and just basically run 2 parallel concurrent phase 1 studies to define that. The truth is that most patients will have been exposed, and that we probably will have difficulty finding cancer patients such as these without exposure, but it's probably reasonable to stratify that separately. In terms of the responses, we have seen that nude mice without a T-cell response respond better to the virus compared to immunocompetent. We have not looked at VIG treatment to see whether that eliminates the response, but as a true oncolytic virus, there's nothing else going on except the virus getting in and replicating and killing these cells, as far as we can tell, and the ability to do that is affected by the immune system, and so pre-immune status will affect most likely the responses. But that's why we're interested in now getting to humans and doing these trials and studying this in the context of their immune reactivity. The other issue is, should we be more specific about studying the immunologic status of these patients? Again, our studies have demonstrated safety of the virus in nude mice without a T-cell response, and therefore we do believe that this is safe. The original goal was to do a careful history and physical exam, and if we suspected some immunologic disorder, that we would then work that up further and potentially exclude those patients. And this is not dissimilar to what is done for patients receiving vaccination of replication-competent vaccinia for smallpox vaccination. So I do believe that is safe. The one test that would be probably worthwhile is a CD4 count, and that way patients that are immunosuppressed because of their cancer, because this is a population of patients that may be more immunosuppressed than what are usually vaccinated in smallpox vaccination programs, that would eliminate those patients. And so that would be my addition to the protocol, is to make sure everybody had CD4 counts. The HIV testing, we will clarify and do both RT-PCR and antibody tests for HIV. And the octreotide scan issue is one of cost. I think it would be helpful to obtain these scans. They are very safe, but we need to spell out the radiation exposure to the patients more carefully, both in the consent and the protocol itself. We have been somewhat vague in terms of which patients will receive this because of the cost issue of that study. And right now we are limited in that way. But and so initially our goal is to achieve or to perform the octreotide scan in the last 3 patients that are treated at the maximum tolerated dose to define the maximum tolerated dose. So once we get to that dose where we think we'll see the biggest difference and have the biggest payoff for that study, we'd anticipated then studying those patients a single time with an octreotide scan. We will spell that out more directly and may leave some flexibility in case the funding comes through so that we could do this on more patients. We will also use their own tumors as internal controls, because a lot of these tumors do express somatostatin receptors and may take up the isotope in the absence of the virus. I think I addressed everything there.
I think there were 2 more guidelines for the source of vaccinia immune globulin and when
Yes.
you'll use it.
Yes, we will add that. The VIG is available through the CDC, and we also have cidofovir as a clinically available drug that's an antiviral, and we will specify the use of those in the protocol. That's a good.
And how about limiting contact with young children?
And we will
limit
limit contact with young children.
Okay. Dr. Franchini, was there anything else that you wanted to ask Dr. Bartlett? Okay, thank you both very much.
Diane, why don't you just let him stay up
Dr.
there?
Bartlett, why don't you stay there, and we'll go through our next 3 reviews. Next is Dr. Childress.
I had a fairly long list of suggestions for the revision of the consent form. Most of the relevant information is there, and the form is generally clear, but I thought there were several points that needed further consideration. And during the presentation, initial presentation today, I did receive the materials that were circulated and the responses to the suggestions, and I will just say at the outset that I think the investigators have done an excellent job in responding to these points. I think it's really a superbly revised consent form. But I understand that for purposes of the record, I need to say something about each of these points. Is that correct?
Thank you.
All right. So first, inconsistency between the consent form and the protocol in terms of the number of tumors that would be injected for each patient. The consent form said up to 4. The scientific abstract and non-technical abstract stated 1 to 3. And so this has been changed to up to 3. Intention to request autopsy. The protocol or the response to Appendix M had indicated that the autopsy would be requested, and it seemed appropriate to have some indication to the participant in the research that a request would be made if the participant died in the course of the research. Then there were several points I thought could use further clarification. One had to do with 2 statements about the risk of the altered vaccinia virus that appeared to be inconsistent with each other. And one seemed to suggest basically that this could be done used without any injury to normal parts of the body, and that was stated as a fact. But elsewhere in the consent form, there was a suggestion that the virus may cause damage to normal body parts. And again, this has been rewritten to keep open the possibility of damage, but referring to the evidence in the animal studies. Another clarification had to do with the second gene that was mentioned, which is added to the virus, but there was a statement that this would not be used in the study, and it seemed to me that a prospective participant would like to have a little additional information about that, and again, a fuller statement has been provided, and I think it's a quite good one. Then, in the section of the consent form that was headed study visits, I thought this might be expanded to include various procedures, since much of what was discussed under the visits really had to do with the procedures. And I thought this whole section could probably be rewritten to indicate in general the expected number, timing, and length of the visits, as well as what would be done during the visits and follow-up and so forth. And the investigators have provided an excellent revision that lays these points out in clear, but I think not excessive detail, so that a prospective participant would really have a good idea of what's involved. Then there was one sentence that I thought was unintelligible, and that has been clarified. Section entitled Stopping the Study, I thought covered too many activities ranging from withdrawal of the participant to termination of the study. And I thought it'd be clear to distinguish these several components rather than grouping them under a heading of stopping the study, which at least to me suggested ending the study itself. But then there are various other possibilities, such as the participant's withdrawal or the removal by the physician of a particular participant for medical and other reasons. And this has been distinguished, these elements have been distinguished, and the revision, I think, is very clear. Another point had to do with the pregnancy test being required at the outset as an exclusion, pregnancy being an exclusion criterion, but then a statement that the person could be withdrawn from the study if pregnancy occurred, but there was no indication that pregnancy test would be performed during the study, and that I thought that it would be appropriate for the participant to know this in advance. And again, this has been clarified as well. We often encounter in consent forms concerns about therapeutic misconception on the part of subjects or participants, and in general, the consent form in its original form avoided language that might be confusing in this regard, but there were a few places where I thought the language could be further modified, including the language of therapy and treatment. And the investigators have made the appropriate changes along those lines. And then I listed a few minor points that I won't go into.
Thank you very much. And Dr. Childress has reminded me to remind you that during your discussions, it's important to state all of your original concerns and then to comment on whether the principal investigator has addressed those concerns or not, even if they have done so satisfactorily. And that's for purposes of public discussion and public record. Let's go to Dr. Demetz.
Thank you. I had essentially two points in my review on the design. I'll work at them in reverse order, since the second one had to do with the use of the term intent to treat, which I thought was not quite, at least as my understanding of it, and that correction or change has been made in the protocol. The use of the term has been dropped. The first point had to do with the design, the dose escalation design. It, as was described just a few minutes ago, it is a classical cancer phase 1 dose escalation process, which and there's some very nice tables in the protocol that demonstrate what you are likely to learn about various dose-limiting toxicities from a design such as this. My question or my concern has to do, I guess perhaps partly lack of understanding of how all of this works, but in cancer trials you're trying to load up the patient with as much dose as you can. That is, more is better until the patient can't tolerate it. In this setting, I don't know enough probably about this to understand correctly, but it's not clear to me that more is better because the process is replicating. So I don't, the virus is replicating. So I don't know if that's true, but the design that's being used is designed for finding a dose under the assumption that more is better. So I'm not saying I not know that there's a correct answer to my question, but just to make sure we're clear that we are using a design that has a certain assumption of what it's after, and I don't know for sure myself that is still the same correct assumption in this setting. So we're experimenting here with designs in some ways, but this is something that I think is an open question to date. The second point, or the second part of the comment on the first point is, in your response and in your protocol, you sort of obviously want to see what kind of response rate you get for the doses that you test. My only observation is that you could easily have a response rate, let's say, of 20% or larger, and do 10, 12, 15 patients and get no response, and still have a underlying true response rate of 20%, let's say. So that if you may not be testing enough patients to find a response, and if you were to give up, not proceed to the next stage or next phase with the number of patients you're studying here, you may in fact have missed something that would in fact be, well, you have to define what interesting means, of course. What response rate do you want? But if I used to use 20% as an example, you might miss it. So the so-called Guillen design, which is an old model used in cancer, in fact assumes that with a 20% response rate, if you fail in 14 consecutive tries, then you give up. Well, you might not get to 14, I guess, even with a response rate of 14. So my comment is just to alert everyone that if one of your goals is to find out should you go on to the next stage, the next phase from this design, you may want to rethink how you use the data for designing or for making a decision whether you go on to the next phase. Those, I think, are my two primary comments.
Thank you very much. Dr. Johnson. Dr. Philip Johnson.
Not to be confused with Larry. My review was very much in line with Dr. Franchini's, but let me ask the question. Dr. Franchini proposed an interesting experiment where you would study your model in the setting of pre-existing immunity, and I think you had mentioned that as well. And while I agree with you, and I think the data support the safety of the approach, what if you had done a study where you either had vaccinated animals or you had animals that you had pre-treated with vaccinia immune globulin and had achieved a certain level of immunity, and there had been no effect? Would you be proposing the current study?
Yeah, the issue is that it's hard to model the pre-immunization in animals. The majority of patients that have been vaccinated for smallpox have been vaccinated somewhere between 10 and 40 years ago. And there's no way to kind of achieve that same level of vaccination in animals. We have studied pre-immune mice, and the vector is cleared very quickly, and the tumor responses are much less. Now we've looked only at the systemic delivery, not at the intratumoral delivery.
Were those data included in the package?
No. In fact,
I didn't see them.
In fact, those have been kind of pilot studies that we have not formally put together.
I see.
The evidence that we do have is that patients in the prior intratumoral injection trials of vaccinia, most notably by Mastrangelo et al., have been injected have been vaccinated immediately prior to treatment, they still demonstrated vaccinia replication in the tumor upon injection of their therapeutic and tumor responses. And so I think this is an incredibly important issue for this vector in general, but I don't see any way that we are going to get the information that we need without a clinical trial. And so the goal is not to boost their immunity against the virus immediately prior to using it, but study what baseline immunity they have and follow the responses and see what correlates with responses.
Let me just go over the points that I had raised briefly in my review. The first point was that the trial is proposed to enroll subjects with superficial tumors, and the protocol suggests that most of the subjects will have either melanoma, squamous cell carcinoma of the head and neck, or breast carcinoma tumors. And I had questioned whether this heterogeneous mixture of tumor types would interfere with data analysis, simply because you'll have a variety of different milieus into which the vaccinia will be injected, and whether or not you can draw any conclusions based on one response or another. And given the number of patients that are to be enrolled, does this further reduce your ability to analyze the data, thereby reducing the statistical power that Dr. Demetz was talking about? The second point has to do with this pre-existing immunity. It is clear that most of the subjects that are in this trial will have been exposed to vaccinia. And while it is hard to predict, I think, which ones will have a primary response and which ones wouldn't, it is clear that many of the patients will not have what would be considered a primary response to vaccinia. I've been personally vaccinated 4 times in my life and had a primary response only once. The other issue with this is that the protocol calls for repeat cycles to be spread apart by 3 weeks, and it is very unlikely that after the first dose, if there is a response to the first dose, that any of the subsequent doses will have responses, simply because vaccinia is a great vaccine. The other points were minor. I am still unclear about the octreotide studies. These tumors, in fact, I think will express the somatostatin receptors, and it's unclear to me how you're going to gate on whether or not there is local expression or not, and how this will be useful to you. And finally, I had raised the point that throughout the protocol, the experimental subjects were referred to as patients, and I think that that terminology should be avoided.
Dr. Bartlett, any comments you want to address to Dr. Johnson's questions?
In terms of the different tumor types, nothing in our preclinical work suggests that the histology predicts response, and all histologies that we have tested have shown selective replication and response. I also don't believe that there would be any difference in toxicity based on the histology. And therefore, we'd like to include all of these tumors to enhance accrual, but also to get a sense with each histology, if there's any hint that one is better than another, to further direct the phase 2 studies in terms of response. So that would be our reason for including multiple histologies, anything basically that's accessible to the needle.
So you wouldn't see just making this a study of head and neck cancer or a study of malignant melanoma? You just want to take all comers and see what happens? I would prefer, again, hoping to see something that triggers our direction for phase 2 studies, and also to support what we have seen preclinically, which is that there's no histology predilection. The octreotide scan, the intent was to have the patient as their own controls, assuming that they have multiple tumors, some of which will be injected and some won't.
And again, the plan was to utilize this scan in the patients at the highest dose of virus where we would have the most chance of seeing a difference. While most of these tumors have been described with receptors, the imaging, to my knowledge, has not been sensitive enough to where certainly they're not clinically utilized for head and neck, breast, or melanoma on a regular basis. So our hope would be that we would be able to see a difference, but I think there's certainly a question mark there.
Have you tried this in a preclinical model to see if it actually works?
We did, in our mouse model, deliver the octreotide scan, the virus, followed by the isotope, followed by a scan, and demonstrated that there was increased uptake by taking the tumors out and measuring the radioactivity, but also the ability to image the tumors on the scan.
Dr. Bartlett, what is your hesitancy to utilize a more homogeneous group of subjects in the study, rather than the heterogeneous group of cancers that you are proposing?
My only hesitancy is to obtain as much information as we can from this initial study to be able to look at different histologies and really see if this virus does the same thing that we expect it to do preclinically, which is replicate as efficiently in a squamous head and neck cancer as it would in a breast adenocarcinoma. So really just to get a good sense, because our next studies would certainly be dictated by that, and to run too many studies focusing on each histology, I think would be difficult.
Are there questions or comments for Dr. Bartlett from other members of the RAC? Ms. Kwan.
I'm trying to understand putting together Dr. Johnson's remarks and Dr. DeMetz's remarks, and I'm wondering whether a conclusion to be drawn when you put the two sets of remarks together is that the way the study is designed, in fact, they may have a strategy that is efficacious, but it wouldn't be picked up because there's just too many odds that it won't happen, and therefore something that is working would be discarded. Is that a correct conclusion to draw from the combination of the two reviewers?
Well, as Dr. Johnson pointed out, there's several variables moving at the same time, and you could get lucky, and it wouldn't matter which tumor you were after or which site. But the sample size is small. As I said, your design is to find out how much of this you can give before you hit a dose-limiting toxicity. And you do not have adequate sample size to find out is there a response rate, assuming it was homogeneous. And if it's not homogeneous, then you really won't find that out. But the trial wasn't designed to find that out. So it's a perfectly adequate design if you're trying to find out a dose-limiting toxicity of the level of a third to a half of your patients. That is what the design is for, and it will do that as you have outlined. But the other things that you speculate you'd like to learn may be long shots because of all the variables that are changing. That's where I would summarize.
My expectation obviously is high with the virus, and our goal is a more systemic delivery of this virus. So personally, if at the maximal tolerated doses we're injecting all of this virus into a single tumor and it's not responding, or we're not seeing at least encouraging results, or there's some other explanation, including the pre-immune status, I'm going to be very reluctant to push ahead with this virus into phase 2 studies, even realizing that we may have missed a local tumor response, because our ultimate goal is for a more systemic therapy, or at least a regional therapy. So I'm not as interested in just that local injection. Now, we will look for replication and a variety of other things that might point us towards success in a phase 2 study that somebody may want to pursue. Obviously, this is a similar problem with other oncolytic virus studies, as well as other vaccine studies, as well as other non-biologic chemotherapeutic studies. But I think the question is whether, if you saw no response, no effect in all the patients treated, whether it would be worth pursuing because you may have missed some. My gut feeling is that I would not want to put the effort into pursuing it if I haven't seen something in even the small number of patients that we would treat on this study.
I had two questions that have to do with the vector, in that you have two transgenes in there that I'm not clear you're using. One is the CD, and the other is the somatostatin receptor, which either you're using it as a tumor antigen or you're using it as a marker, and you're not even using it in everyone. I guess it's in the vector, but you're only analyzing it in one group of individuals. And particularly with the CD, I guess I wasn't clear on your explanation at the beginning of why you include it. Are you planning to use it in a subsequent phase to kill tumor? Or if you're not going to use it, how does it help you having it in there from a safety standpoint if you're not going to combine it with the therapy that it would be required, not therapy, but the agent that would be required for it to have its effect? So if you could just maybe clarify your rationale for the design of the vector, particularly the inclusion of these two transgenes that may or may not be useful to your study?
Our ultimate goal would be to utilize the cytosine deaminase gene to convert 5-FC to 5-FU in tumor cells. However, the complexity of the study to utilize in this initial phase 1 study, it would actually require 2 phase 1 studies, I believe. First, the virus alone, followed then by the prodrug at increasing doses. And so the question is, do we go immediately after this study to a new phase 1 study with increasing doses of 5-FC as a prodrug, which we may, if depending on what we see in this study, or do we go on to other phase 2 studies with the virus alone, followed by then a phase 1 study using the 5-FC? That we haven't defined, but the ultimate goal is to use that prodrug. We have seen mixed responses in vivo where the prodrug activation shuts the viral replication down and can slow down the response to the virus alone. Whereas we've also seen examples where the prodrug activation does improve the response. And so it's complex to study, and we just wanted to start with this. The fact that that CD gene is there in addition to the other 1,000 proteins that vaccinia produces, we do not believe it's going to be harmful in any way as a new protein, or that it would enhance in any way the antigenicity of this vector. So we don't think it hurts to have it there, and our plan is to use it in the future. And basically the same thing with the somatostatin receptor. It would be great with a clinically utilized scan to be able to image gene expression, especially when we get to deeper tumors that aren't accessible to our needle. And so that's the goal with that product, gene product. If we demonstrate in this study at the highest doses that we're going to be using in phase 2 that we see gene expression, then we would apply that to subsequent studies.
Are there consequences for expressing the somatostatin receptor in non-tumor tissues?
As far as we know, there's no consequence. The somatostatin receptor does exist in non-tumor tissue. In tumor tissue itself, people have considered that an anti-growth receptor and that it might inhibit growth of tumors. But we don't believe that in non-tumor tissue that would have any untoward effect.
Dr. Samari.
I'm just trying to sort of catch up back what Dr. Johnson and Dr. Demetz. The primary endpoints are to determine a maximal tolerated dose and safety. You've mentioned efficacy several times and your desire to look at a number of different tumor types. The two issues that remain, the heterogeneity of the population, include the tumor type and the immune status. So can you just, again for me, do you have any suggestions or any concerns that a different tumor type or a variable immune status in the patients will affect either the maximally tolerated dose or safety? And if so, how does this affect the design of the number of patients involved?
I see no reason that the histology would affect the safety or maximum tolerated dose. We just have not seen variability in replication based on histology in our studies.
And that's based upon how many preclinical histologies that you've tested?
We've tested the human melanoma in athymic mice, a rabbit VX2 tumor, a rat sarcoma, a human colon cancer, murine colon cancer, and let's see, I think that's
all subcutaneous.
That's it.
All subcutaneous.
As subcutaneous tumors. And nothing about the virus or the virus uptake would suggest a difference in toxicity based on histology. So I don't think that would affect it. I do believe the pre-immune status should be considered, and that that a separate stratification for those that have not been pre-immunized is reasonable. Or
for
that
this study?
For this study, okay. Or without circulating IgG against vaccinia, those patients should be stratified separately in a separate phase 1. I think that's a reasonable thing. I do believe, based on our studies in nude mice and our non-pre-immune primates, that we'll be able to achieve the maximum feasible dose without toxicity, because we've gone to 10 to the 8th plaque-forming units intravenously as a systemic injection in non-human primates, small non-human primates. So I believe it's all going to be safe, but I think the clearest thing would be to stratify in a separate phase 1 escalation those patients without pre-immunity.
Other comments or questions for members of the RAC? Yes, Dr. Franchini.
Yeah, just want to make another comment that, if you stratify really the patients, even if you have few, you might end up seeing better effect in individuals which are not pre-immune, and therefore you might not throw out a safe and possibly effective vaccine. Approach, for cancer. Because my concern is that if you might end up getting the results which are not really reflecting the reality, but just the fact that the individual was previously immunized. So in the future, we will have a lot, presumably, generation of people that will not be immunized with the smallpox vaccine.
Other comments? Members of the public, any comments, questions? Dr. Johnson.
I hate to keep revisiting the same thing, but the somatostatin receptor concerns me. And it's a question of to me, it's a question of developing a therapeutic versus developing a diagnostic. And at least reading the synopsis of the protocol and the information that you presented today.
Excuse me, sir. Okay. Sorry. Can you speak into your directly?
I am.
I wasn't getting.
But the point that I wanted to make is that you're developing a therapeutic. You have criteria that you will use. You're developing a diagnostic when you use it. If you're not using it as a tumor antigen, then you're developing a diagnostic. And there are no criteria put forward. There's no validation of this technique. We've seen no data on the utility of this technique. And in the absence of that, I'm concerned because there appears to be less of a reason for it on that basis. And I can see the CD where it would be useful down the road, but if it's just a diagnostic, then it's got to be validated, and that's my only concern about it. Validated, or, in my opinion, it shouldn't be there. Or at least have a plan for validation of it. Or have the data support that it's going to be a useful thing. I mean, expressing the somatostatin receptor is something that I saw in a grant review about 6 years ago in order to try and follow gene transfer. I have yet to see the widespread application of that process or the validation of that process. And so I think there ought to be some plan or plan to use it at some point, and I just haven't seen that from your presentation. And that's my concern.
I think, we would, the preclinical data, not just by our lab, but by others, suggest that that is a means of imaging gene expression in vivo, and it has the advantage of a clinically available scan that can be utilized without verification of the scan itself. We're not proposing it as a diagnostic in trying to image tumors. We're proposing it as a diagnostic, as an imaging modality of correlating with viral replication and gene expression, which we should clarify further in this study. Unfortunately, again, for financial reasons, we did not propose the validation of that scan in this trial. That's something we would love to do in subsequent trials, but we didn't propose it in this. So then I think the question comes with that transgene, is there something harmful of having that transgene in the virus, especially if we're not going to use it? And I would argue certainly that of all the thousands of genes within vaccinia that we know are injurious to cells. I mean, that's why we're utilizing this virus as a means of killing cells, that the addition of somatostatin would not in any way make this virus more virulent. There's just nothing that would suggest that. And so I think it's safe to have in there and doesn't alter in any way this virus. And we would love to validate it in future studies, but did not put that in the design of this study, where we're basically just looking for toxicity of this vector overall.
Can I make a comment, please?
Certainly. Thank you.
So one thing to try to answer some of these questions, which I think, everyone needs to be aware of. We have sort of a policy where when we have vectors that are submitted and we have clinical trials, if there is a transgene present, we expect it to serve a function. If it doesn't serve a function, then we ask to have it removed. Okay, so I think you're going to need to reassess this, and just assuming that it's there and it's not having an effect isn't good enough. Okay, so you're going to need to show that A, it's not expressed, that B, it doesn't have a deleterious effect, that there is no immune response to it, and you are going to have to justify why you actually have it there. I mean, if you have it there because you want to use it as part of the clinical study to then see if the virus replicates so that you can then treat, okay, with your prodrug, that's an option. But I think you really need to consider why it's there now, in the clinical trial as it stands now. So, but anyway, I want to make it clear to the committee that we just, don't have transgenes present just because they're there.
Because it didn't make any sense. Dr. Simic, thank you for your clarification. Yes, Ms. Kwan.
I wonder if you could respond to Dr. Philip Johnson's second comment about the possibility that the repeat cycles will have no effect because the population was originally, even if it wasn't originally immunized, it would become immunized quickly.
I don't believe we can tell until we do the study, but I agree that the likelihood is that the subsequent injections will not be as effective. The only data that we do have in clinical trials is the Mastrangelo study, where they were vaccinated first, then injected intratumorally. They did show viral replication in the tumor and a tumor response. And obviously with direct injection of the virus, it's a little different and perhaps not as exposed to circulating antibodies and immune effector cells, so that the direct injection approach may allow for response with multiple injections. In a sense, the vaccinia is a good vaccine because smallpox was a very stable virus over time as opposed to other viruses. It's not much different than other vectors in this arena, and those have demonstrated in the pre-immune state and in multiple injections that gene expression and replication does occur in patients. And so I think we have to look at it, and he may be right, but we'd like to see that for sure.
I think the discussion surrounding the points that have already been raised is very complete. Are there any new issues, points, discussion that either the public or members of the RAC would like to raise? Okay, Dr. Bartlett, thank you very much.
Thank you.
What we're going to do is to break until 3:10. We have to keep on time because of the webcast. So we're going to break until 3:10, then reconvene and present our summary and take a vote. I'd like all of the reviewers to remain, and anyone else who'd like to participate in this small experiment. And other RAC members who would like to participate in this small experiment to remain, and we'll try to make it fairly concise. Otherwise, we'll see everyone back at 10 minutes after 3. Thank you.